Welcome back to the American College of Surgeons, bulletin brief from the front lines, Surgeons' Voices. With me today is my friend, Professor Neil Mortensen. Professor Mortensen is an honorary fellow of the American College of Surgeons and is president of the Royal College of Surgeons of England. Welcome, Neil.
Well, it's very nice to be here again, Steve, and nice to see virtually all my American friends. These are tough times, and I look forward to seeing some of you face to face again one day.
We all hope for that same eventuality, and hopefully sooner than later. It's been about a year since you and I last spoke, and when I interviewed you last year, we were sort of just getting into what now we know was the first wave of COVID-19, and things have changed. They've gone up and down in waves, as suggested, ebbs and flows. Can you tell us a little bit about how the affairs of the college have changed during the last year with COVID-19?
Yeah, absolutely. So isn't it interesting how quickly that year's gone by, and how I'm still here in my home office without a tie on. The College of Surgeons in Lincoln's Inn Field is being rebuilt. During the first surge, we closed our temporary building, and all the staff work from home. During the summer, as things settled down, 2020, we had a bit of a return to the college, but because we were moving out anyway, we didn't move everybody back. And then, of course, with the summer, there was a relaxation of all the appropriate social distancing, etc., etc., and we got another wave. We had a sort of blip come October, November, but then we had a really bad time from December on, and we had nearly completely overwhelmed critical care capacity in the UK, and we had nearly overwhelmed cancer facilities, nearly. Part of the problem was that the government and the NHS tried to get surgery going again, let's say August, September, October, because it had stopped very largely during the first wave. And then, of course, the hospitals were full of both quite busy elective plan schedules, and then all the emergencies coming in too. So it was a double hit. And that made actually this second wave more difficult than the first wave.
So what happened to hospitals in the UK? Were there sort of hot hospitals and cold hospitals, or did every hospital fend for themselves where they had some hot and some cold areas, or was it a mix?
It was very mixed. It depended on how bad the virus was. It depended on local geography. So I've always said that in Oxford, we were particularly fortunate because we didn't have one great big hospital. We had three separate hospitals. The main John Radcliffe Hospital, just to give you it as an example, was our acute hot site. And then we had the Churchill Hospital, an old American hospital, which you may remember we've talked about, named after Winston Churchill, where mainly the cancer surgery was done. So that was planned and that was kept cold, in inverted commas. And we also had a separate orthopedic hospital, which, although some of its staff and facilities were repurposed for COVID, mostly the orthopedic surgery kept going too. Well, you contrast that, for example, with Cambridge, Addenbrooke's Hospital. It's a brand new build, everything on one site, everything within the same building. They found it very difficult to carve it in two and have a green half and a red half. Because obviously in the UK, we've been used to staff moving from the hot side of the hospital to the cold side. Go and do your acute appendicectomy, come and see your anterior resection from yesterday, all that kind of stuff. Obviously, when you have a very high prevalence of the virus, you just can't do that. You have to have completely separate sites. So coming back to your question, some places did very well, some places did very badly, but there was quite a lot of mutual aid, as we've called it. So we had patients in London with cancer surgery going down to Bristol or going up to the northeast, for example. We had some critical care patients being moved in pretty difficult circumstances to different parts of the country. So there was a sense in which everybody was helping each other out. But the most successful places were those which had separate facilities for hot and cold.
So speaking of separate facilities, and you mentioned the virus and staff, what's evolved in terms of staff, vaccinations, testing, for example? and then also patients, prior to surgery in terms of testing the patients, vaccinating patients.
Okay, so let's talk about the staff first of all. So during the first wave, we as a college in the UK campaigned for testing for all staff. And as with the PPE, the personal protection issue, there was a certain amount of smoke and mirrors. And obviously, in the end, it turned out the reason for the authorities not being completely open with us about it was that there was not enough capacity. In other words, the supplies were poor, both for the PPE and the testing. Well, eventually by late June, early July, we got to the point where we persuaded everybody that testing for all staff twice a week was absolutely the way to go. So that came in. Then, of course, we'd had vaccination from December, and there's a very good take up in hospital staff, although it's interesting, it's still only around 85, 90%, it's not 100%. And we were having a discussion the other day, as surgeons, we're used to having Hep B vaccination because of the kind of work we do. And there's been some suggestion that staff should be forced to have vaccination too. In the UK, the view has been it's all about deployment, not employment. So in other words, so if you as a surgeon say, I'm sorry, I just don't like the idea of the vaccine, I can't take it, then you'd be deployed to a part of the hospital service where you weren't putting patients at risk in inverted commas. It's not the same as Hep B, obviously, but it's a similar sort of situation. So at the moment, we haven't had too many examples of that. And as, if you like, surgical leaders, we're obviously persuading everybody to have vaccination if they possibly can. As regards patients, we did the whole quarantining for 10 days, self-isolation, testing before you come in. And actually a recent study by Omar Faiz, who you may know, he's at St. Mark's and does some of the sort of national, what we call HES data, that's a national database. Although if you had COVID, you had a higher mortality rate, we know that from figures from around the world. In the UK, the overall figures for both emergency general surgery and complex planned abdominal surgery were no different year on year from 2019 to 2020. So we were doing something right. The incidences of patients getting COVID in hospital were actually quite low. So places were trying really hard and doing a good job to try and keep people safe. I guess there was a bit of gaming around not doing too many complicated operations during the height of the surge and saving them up till things were better. But on the whole, we've got a bit more relaxed about doing major surgery in the time of COVID, because provided we do all the right things, quarantine the patients, have the staff tested, have the patients tested, have a reasonably safe environment, then we can do safe surgery too.
Great. So we've covered a bit on the faculty side and on the patient side. There's also the trainees. And I'd be very interested for our American College of Surgeons audience to hear how the Royal College of Surgeons in England is dealing with training. How much of that has gone to virtual, for example? Can you do skills courses in a virtual sense, like the MATIS units throughout the UK? And also, as we hopefully go back more to in-person, do you imagine some of these virtual educational events will continue?
It's a very good question, and it's been a crisis. I say that the trainees have been the, if you like, the inadvertent casualties of the crisis, because if surgery stops, training stops. Certainly in craft specialties like ours, you can do the knowledge virtually, but you can't do the hands-on virtually. There is a lot of interest, obviously, in simulation. And I think in early years of surgical training, simulation is good. But when it comes to the really tough, big cases and the decision-making and the appropriate steps to take around a difficult, complex surgical situation, it's very, very difficult doing that without actually having first-hand experience. So all our trainees have logbooks, and I have to tell you, for most of the year groups, up until year 7, the logbooks are deficient. And our guys normally get what we call certificate of completion of training in year 7, and around 25–30% can't complete their training right now because they haven't got sufficient numbers or competency. So there's a bit of a crisis. The pipeline has to have people going out the other end to be able to afford putting new people in at the bottom end, as it were. So there's lots of discussion around extensions and paying for the extensions. There's lots of talk about people going into fellowships and completing their competency within a fellowship. And we've even discussed the possibility of a special kind of early years consultant position, staff position, where people are mentored and looked after, because this class of COVID, I think, will be a special class of surgical trainees who will have been badly disadvantaged. I think we have to do our very, very best by them to see them through what I think is a really tough time. We have a campaign going around the UK at the moment. Every operation is a training opportunity. No operating today, no surgeons tomorrow. So there's a big, big encouragement to both the system and our colleagues to see every operation as a training opportunity. But of course, if we're trying to get back to volume to get rid of the backlog, I can tell you a bit about that in a minute. If there's volume, it's very difficult to train really well at the same time. I think there are real tensions there between getting the work done and getting the training done really well.
Interesting. It seems like a throwback to the days before the modification in the training schema, when you had, the junior house officer, senior house officer, and so on and so up with the ladder, junior registrar, senior registrar, and people just sort of stayed on. The system's vastly improved, but it seems to have taken a hit from COVID. But why don't you then tell us a bit about, you just touched on it briefly, but why don't you carry on that last?
Well, I know you Americans see the NHS as a communist system. I'm joking, of course. But it is a national system. There is a private sector, there is an independent sector, and just to briefly mention that, the independent sector has been used for capacity and will be used for extra capacity in the next few years. But in, let's say, a population of 60 million, there are now 5 million waiting for surgery, and of those, there are around 400,000 who've been waiting more than 52 weeks. So that's pretty bad, and quite a lot of those are orthopedic cases, quite a lot of eye surgery cases, some general surgery, some urology, quite a lot of ENT, for example. And so there's a big public debate. In fact, there was a debate in the Houses of Parliament today around waiting lists and what can be done. We have, rather like Roosevelt, put forward the idea from the College of Surgeons in the UK, the idea around a new deal for surgery. In other words, don't just assume it can happen. We need the resources to make the return of surgery happen. So I think in terms of our capacity in the UK, we're hoping that we'll get back to 100% of capacity by maybe October, November, as hospitals reopen. But 100% capacity is not going to make any difference to a big wait list that's already there. And then we're talking about these hidden patients too, the ones who are scared to come up because of COVID, the ones who maybe haven't been diagnosed yet with their cancer, the ones who will have a more advanced cancer, which will be more difficult to get out, take more time. That will affect capacity. So it's a massive, massive national problem for us. And I guess we either will or won't succeed with our New Deal, but it's pretty tough on the punters sitting there waiting for their knee or their hip operation and no sign of it being done. When, as you and I know, some of these operations aren't routine operations. We call them routine, but for those people, they're not routine at all. And these are really what we call the little miracles of surgery. It's stuff that works. It's stuff we can give people. It transforms lives, a new hip or a new knee. It's absolutely fantastic stuff. To not be able to provide it is deeply frustrating.
Yeah, indeed. And it sounds like, unfortunately, you're experiencing many of the same problems on your side of the Atlantic that we are here, whether it's resident case volumes, whether it's hospitals not being able to accommodate the demand, whether it's the pent-up need of patients who know they have disease or the ones who have not even yet been diagnosed because they haven't gone for their screening or their surveillance. Very, very similar problems, albeit without the single payer of the NHS. But as you say, you have your Bupas and your Nuffields and Cleveland Clinic Londons and other places. So very, very similar problems. Before we wrap up and sign off, give you the opportunity to add any other remarks which you may care to make.
No, only that I think the crisis has shown us that we can do all this stuff remotely, even if it's not the same fun as meeting up face to face. I think in the UK, it's been tremendous for getting people together and working together. I think if you like, the digital transformation of what we've done has been absolutely superb. And I guess some days it's actually better not to get on a plane, and maybe it will be better to speak like this if there are short-term issues or immediate issues. It is brilliant to talk to colleagues around the world about how they're doing and their particular problems, and maybe share the solutions too.
Well, thank you very much. I definitely agree. We do miss that camaraderie, certainly, when we had our annual clinical congress and we're doing it virtually. And upcoming soon is our annual quality and safety conference, and the same. It'll be virtual, and it's certainly not the same as sitting together across a table somewhere, but it's what we have for now, and it is efficient and it is cost effective.
Just the very last thing, Steve. The Royal College of Surgeons of England is in a finishing stages of a remake, and we're getting the keys at the beginning of May. We're moving all the staff in June, and it's going to look absolutely magnificent. So come and see us maybe July, August, September onwards.
Looking forward to coming back. Thank you. Good to see you.
Bye.
Bye.